Good evening. Today we are going to discuss about abnormal uterine bleeding and its management. So, abnormal uterine bleeding or AUB is defined as bleeding from the uterine corpus or the body of the uterus that is quite abnormal in volume, regularity, or timing. So, see, when a woman comes complaining of a change in her menstrual pattern, say in volume, in regularity, like she may say she's having short cycles, long cycles, any change in flow, whether she's passing any clots, these are all belonging to a classification of abnormal uterine bleeding. There are various causes of abnormal uterine bleeding. It varies from like estrogen withdrawal at the time of birth. If a small girl comes with abnormal uterine bleeding, we'll think of any foreign body, any trauma to the lower genital tract, any infection, for example tubercular or any kind of yeast infection, any abnormal ovarian tumor, any sarcoidosis botrytis, that is the tumor of our lower genital tract. Other causes like anovulation, which is very common in women who are like into the teenage, like when they go into the teenage, around 15, 16 years, they have various anovulatory disorders which lead to abnormal uterine bleeding. And also infections, coagulation disorders are very common in this like premenarchal age group girls. Other when the woman is around say around 20 to say around 40 years of age group, the most common cause are anovulation followed by any hormonal contraception, and most important, pregnancy. So any case of abnormal uterine bleeding in the reproductive age group, first and foremost think of pregnancy. Other causes like polyps, myomas, and especially when a woman transitions into her perimenopausal age group or say around menopause, the more common causes are like polyps, myoma, endometritis, that is the infection of the endometrium, and also hyperplasias, that is abnormal proliferation of our endometrium, and also cancers. So we need to do a detailed workup when we see a woman with abnormal uterine bleeding. First and foremost is history taking. When was the onset of menses? When she had her menarche? How was the volume, duration? Whether she had any intermenstrual bleeding, like bleeding between periods? Any temporal association? Whether she had this during her coitus, like postcoital? Whether it was coming after childbirth, like postpartum? Any associated symptoms like dyspareunia, dysmenorrhea, galactorrhea, hirsutism, any underlying systemic causes like renal causes, hepatic causes, hematopoietic causes, any medications is taking like hormones, anticoagulants, antipsychotics, we have to rule out everything. And we have to run certain blood tests on her, like a full blood count, and testing for coagulation disorders, for example von Willebrand disease. We have to do a bleeding time, clotting time, and we have to take a detailed personal history on her and do other investigations and look out for iron deficiency anemia, do a serum ferritin test, rule out the endocrine disorders behind this abnormal uterine bleeding by doing a thyroid function test, doing a prolactin assay, and all these tests are very important. Apart from that, we can do an ultrasound, a transvaginal ultrasound if she is sexually active, or a trans abdominal scan if not. At times women who are like obese, we prefer a trans vaginal scan because the ultrasound will be quite closer to the uterus and ovaries, and we can really pick up better with the transvaginal scan. And endometrial sampling, what do we mean by endometrial sampling? Like we take a pipple biopsy. A pipple means a small like tubular plastic kind of device. It can be done in the OPD itself. It goes inside the uterus, picks up some endometrial tissue, and then we can see the histology, like what are the changes in the endometrium. And also endometrial sampling is very very important in women who have a persistent abnormal uterine bleeding, that is abnormal uterine bleeding not responding to any kind of medication. And also if there is strong family history of cancers, and also a long term disorder like PCOS, obesity, we have to do an endometrial sampling, because these disorders are most frequently associated with hyperplasias and endometrial cancers. And women who are having breast cancers on a tamoxifen need to have an endometrial sampling if they are having abnormal uterine bleeding. And where we don't need to do endometrial sampling, in women who have an endometrial thickness on ultrasound less than 4 millimeter, we just don't do it. And nowadays what we prefer as gynecologists, we usually prefer abdominal scan or a transvaginal scan. If any abnormality is picked up, we do a hysteroscopy. So hysteroscopy is, hystero means your uterus, scopy means putting a camera inside the uterus. So woman is like sedated typically, and we put a small tube, like usually a 4 or less than that also we can use. Put a tube inside the uterus, we push saline to create some pressure inside the uterus, so that the uterine cavity really balloons out, and we can see that yes, there is a myoma or there is something that is causing this abnormal uterine bleeding. We can really figure out the anatomical causes behind this abnormal uterine bleeding. And nowadays we don't do blind biopsies that we used to do in early days. Like, we never encourage doing blind biopsies. So coming to the treatment, so the treatment will depend on the entire clinical picture, like whether the woman is having any comorbidities, having any structural lesions like fibroids, polyps, any pressure, pain in her lower tummy. We have to first figure out like what are the causes behind this abnormal uterine bleeding. Then only we can treat accordingly. So first of all, endometrial polyps. So in premenopausal women, that is, these are the women that are quite like far from her menopausal age group, say around, they're around 38 to 42, 43 years. There is only 1.7% chance of malignancy if they have a polyp inside the uterus. So usually when we do a hysteroscopy, see there is a polyp, we usually take out and send for biopsy. Other causes can be adenomyosis in reproductive age group. So when a woman, you are seeing adenomyotic uterus on ultrasound and she wants to preserve her uterus quite far from menopause, very young lady, always try to give her an LNG-IUS. LNG-IUS means levonorgestrel releasing hormonal device. That is a small like plastic kind of T-shaped structure that you can put it inside the uterus and keep it for as much as many years, like maximum 5 years you can put it. Her like abnormal uterine bleeding goes off. And if in some women, if you try with LNG, you try hormones and it doesn't work, you can counsel her for uterine artery embolization. Uterine artery embolization is a quite a new technique that is done by radiologist. So very new, not well studied. It's usually done in Western world, not much in India. I'll talk about it later. Leiomyomas. So leiomyomas, or you have heard about the term fibroid uterus. So these are kind of outgrowths in the uterus. They can be like submucosal coming from the mucosa of the uterus, can be subserosal coming out of the serosa, can be intramyomural like inside the myoma, inside the layers of the uterus. So they usually increase the surface area and lead to this kind of bleeding. So usually we try to give oral hormone contraceptive to decrease the volume and duration of the blood loss. And most of all, if there is a submucous myoma, if the myoma is coming out of the mucosa of the uterus, usually we try to do a hysteroscopic fibroid removal. As we put a hysteroscope, we also put a kind of a loop kind of structure and try to curate the myoma inside. If we can't do it hysteroscopically, say around it's occupying more than 50% of the uterus, we can do laparoscopically, like put a scope in the tummy, in the abdomen, see and take it out. And the next is endometrial hyperplasia. So what do you mean by hyperplasia? It's like you must have read a pathology. Hyperplasia is increase in proliferation of a tissue. So there are two kinds of endometrial hyperplasia, that is without atypia or with atypia. So without atypia means it's a very kind of benign thing. Like there is only 1.3% chances of going into cancer. And with atypia, atypia means any abnormality in the NC ratio, nucleoplasm cytoplasmic ratio. You must have read in pathology. So atypia are like a little bit of bad things you can remember in that way. So if you see there is no atypia, you can simply give her cyclic progesterones. Like usually we give medroxyprogesterone estate 5 to 10 milligram, or some women they tolerate MPA, medroxyprogesterone acetate. We give norethistron. So we give it for as a continuous therapy for 21 days and stop it for 7 days, or you can just give it for 14 days and stop for 14 days. You can continue for 3 to 6 months. And if there is atypia, it's kind of a little bit of tricky thing. There, if a woman is far from her menopause, is in her reproductive age group, you can definitely try with LNG IUS. It's a better option, and studies have shown that LNG IUS is better than the oral contraceptive pill because it has a like local action which helps in regression of the atypia. And next is the coagulation disorders. Like when do you really suspect the woman is having any abnormal uterine bleeding due to coagulation disorders? First, when her first period comes, when she goes into menarche, she will notice that heavy menstrual bleeding, passing a lots and lots of clots, becoming severe anemic. At that time you will think that she might be having any underlying coagulation disorders. Most common is von Willebrand disease. So you usually bring this women to like, not of course women, these children to the clinics and do a thorough coagulation profile. And in this women there are like many drugs. For example, in von Willebrand disease we usually give desmopressin. And there are some like over the counter drugs that we give to people who come with this heavy menstrual bleeding. Like we don't right away start a hormonal drug until the investigation are up. We usually give them like tranexamic acid. So tranexamic acid has an antifibrinolytic action, usually helps in stopping this heavy menstrual bleeding. And other causes of bleeding are due to chronic endometritis. Endometritis is means endometrium infection of the endometrium. There are various causes, like it can be due to mycoplasma, can be due to gram negative bacteria, and there can be chlamydia, can be due to candida. So we take a biopsy, send it for like histology, and also send it for culture if we really suspect there is a chronic endometritis. On the contrary, acute endometritis is kind of a, they usually resolve on their own and we don't medicate them with like too many antibiotics. And as I saw, the told the first line of treatment is usually an NSAIDs or non like you know that we usually give mefenamic acid, ibuprofen with dysmenorrhea. The same helps with this abnormal uterine bleeding. And the hormonal treatments usually are progesterones, as we have previously discussed. They can be cyclical, they can be like non-cyclical. Cyclical means you give it every cycle, give it 21 days, give a like 7 days break. A continuous one is you give it for 3 months right away, you don't like change and stop in between. And the standard cyclic treatments do not reliably suppress the HPO axis, so they don't prevent any random ovulation and are not contraceptive. For contraceptive, if you want, you can definitely use the combined ones. And LNG IUS is a 52 milligram LNG. There is a 52 milligram of LNG or levonorgestrel. It decreases the menstrual bleeding by around 75 to 95%, and the patient satisfaction is quite good with LNG compared to the oral because it doesn't have any systemic side effects as well. And next is GnRH analogs. So see, GnRH analogs are usually not given chronically, like they are not given on a long term. It's very like unattractive term. So if a woman cannot have an hormone treatment, cannot have LNG IUS, but needs like there is a she needs a some immediate like she's under some immunosuppressive agents and need this immediate treatment of AUB, usually give with GnRH analogs like agonist and antagonist. And they have a beautiful action on endometriosis. If a woman is having heavy menstrual bleeding associated with endometriosis, GnRH analogs are quite good for her. And recently, this uripristal acetate was launched, which is a SPRM, selective progesterone receptor modulator. It decreases the main fibroid volume by 45%, and really, there is a significant reduction in blood loss. But the only thing about uripristal acetate is that it's very costly, and it has a like a problem with the liver enzymes. So women who have a history of liver disease are usually never given. And another thing we can try is a mifepristone acetate, very less used. We usually don't give mifepristone. And the next line of treatment is a surgical intervention with endometrial ablation. So women who are having HMB don't respond to medical treatment, we can try with an endometrial ablation. Usually, the question goes around which method do you use. So we can use NDYAG laser, that is a hysteroscopy guided. You can also try other methods, but these are not very well known. And role of uterine artery embolization, as I told you before, it's quite experimental, usually done on a research basis, done in Western world, not very practiced in India. We usually never advise uterine artery embolization. However, some studies shows that the return to fertility, like after a uterine artery embolization, is if a woman wants to get pregnant and you, and also she is having AUB, then you can try with uterine artery embolization rather giving her hormonal things. But it's, as I said, it's quite experimental. And the last modality is hysterectomy. And if there is heavy menstrual bleeding not responding to anything, she is landing up into anemia. And also in women who are quite like towards their menopausal age group, uh, hysterectomy is a definite method of choice. So the route of hysterectomy, you can like go for laparoscopy, can go for abdominal, can go for vaginal. It depends on the patient condition, where is the uterus, how big is the uterus, what are her desired levels of thing. So you see, and then it depends on the surgeon who is doing it, how competitive is the surgeon taking out the uterus abdominally or laparoscopically. That is also a very important thing. Definitely, laparoscopy and robotic hysterectomy are better in terms of less stay, good recovery, and less post-operative pain. So, route of hysterectomy preferred is always a minimal invasive route, that is via laparoscopy or hysteroscopy. Sorry, laparoscopy or robotic, rather than an open abdominal hysterectomy.